This is to continue the lecture from today that we did not finish on the legal and ethical aspects of psychiatric nursing. So looking at this slide, this is the next slide that we would have gotten to, and I'm starting from here, ethics. And just reading this, you can see the definition that ethics is a branch of philosophy that deals with distinguishing right from wrong. And that's basically what ethics is all about in terms of our own personal ethics and professional ethics, is that we will determine right from wrong. Bioethics then is a term that is applied to ethics when dealing to concepts or with concepts that are within the scope of medicine and nursing and other allied health fields. And this is just a review. So going to the next slide, you'll want to check that out here and look at your terms. And terms to review would include the ethical dilemma. And what is that? Well, of course, that's when we have a dilemma and there's two opposing courses of action, and we can have that internally. And we talked about that kind of with the conflict when we talked about conflicts. So conflicts within what we're feeling about a patient, what should be done or not done, and when there's opposing actions of this. So kind of know that. Don't need to go into that so much. Autonomy, just to review, is that it emphasizes that people have the moral agents to determine what their destiny is. Beneficence refers to, again, one's duty to benefit or promote the good of others, which is what we will always try to do in healthcare and in our contact with people and what have you. And non-maleficence, abstaining from negative acts towards one another, including acting carefully to avoid harm. And that's always a hard one because we sometimes do things that cause harm or pain to people, and we don't intend to do that. And this always feels kind of bad when that happens. The next slide goes to more terms. And justice. Justice is based on the notion of a hypothetical social contract between free, equal, and rational persons. Whatever that means, lifted this probably right from your textbook. The concept of justice reflects to a duty to treat all individuals equally and fairly. So let's just look at that last sentence. That makes a lot of sense there. But that's what we try to do, to always treat others, or everybody we take care of, with equality and fairness. And I think that's a no-brainer. We just do that all the time. Doesn't matter where people come from. Veracity refers to one's duty to always be truthful. And this is a hard one for nurses because sometimes we're not able to tell the full truth to somebody. There's limitations on that. We have restrictions about what we can tell. And so there we're challenged with veracity a lot. I mean, by and large, yes, but people might want to ask us questions, and then we have HIPAA. If it's a family member, we can't tell them things, and we feel somewhat untruthful about that, when in fact it's a law. But it kind of pangs at our heart with this issue of veracity. By and large, truthfulness is what we go for. Okay, next thing. Ethical issues. So in terms of the ethical issues in psychiatric nursing, we will use the least amount of restraint. And this means chemical too. And I already elaborated on this in talking about the legal terms in that, that sometimes we have to restrain people. And in restraining, we need to have good reason, validation for that, and document profusely regarding that. But there have been times where we think that maybe by giving somebody a PRN that might help to calm them down or that they're maybe interfering with the progress of our work. And so that had been a practice in which a PRN, again, was written without any parameters about that. And that, of course, is a problem. We need to, and again, looking at the legal aspect of informing patients, this is, people are due their informed consent, and we need to fully inform patients regarding their disorders of treatment, the issues that are going on with them, but is that always really the case? So you can see where legal and ethical blend between the two in a lot of areas. Ethical issues continue with crossing boundaries now. There are a lot of boundary crossing issues. I believe in your book, not necessarily the ethical chapter. There was a chapter 7, I believe it is, talking about the therapeutic relationship. And there's a really good description of boundaries and how they're crossed. And if you read that, it's quite interesting. And there's some attachments or some references to articles. And you can even Google those articles and see in terms of examples of boundary crossing and studies that show where these happen. And it's unbelievable when you read it, because you think that would never be me. How can anybody do that? And in fact, it's actually more prevalent than you would know. So is it really legal or illegal to do that? Not necessarily. Ethically, that's a problem. Okay. Keeping secrets. We don't want to keep secrets. So we don't want to keep secrets that patients are telling us. And we are trying to be trustworthy and reliable to somebody, but then we have to stop them in their path when they're trying to tell us a secret that might cause harm, like maybe they're hiding a sharp object that they shouldn't have. There's no secrets there. So we have to make sure that we are not allowing patients to, we're not going to harbor patients' secrets, let's put it that way. And so when we do, that might be, like don't tell, or whatever, and maybe it's not a sharp object, but something that's maybe not going to cause pain or suffering to the patient or anybody else, but still it's a secret. You can't do that. And so again, you can see where these ethical issues really do challenge us. And then in terms of confidentiality, you need to know about when it's okay to break confidentiality. And the Tarasoff case I've linked you to a reading on that. That's very important to know, because it is a California case, but is now something that is used nationwide, and it is also in your textbook regarding that. And so we have the obligation, when we hear a secret, like I'm going to kill that neighbor that got me placed in this this institution, or the situation involved somebody else, and the patient will threaten to cause harm on that individual needs to be notified about that. And so read all about that. That's important to know, just so you have that understanding for that. Okay, next slide. The nurse's duty is to adhere to legal and ethical principles. We need to be responsive to the patient and respond to the patient when we are in taking care of them. So we need to be all on board with that patient, and this can be a problem sometimes because our time is so taxed with doing all the other tasks and duties of the nurse that we can't always be there and respond to the patient. We need to educate the patient. Really, this is so important. We talk about this all the time, and this is why we have as a concept a major thread in our curriculum about educating, and why you have to do so many patient teaching projects, because educating patients, their families, significant others, is so vitally important. Okay, you hear that? That's my dog licking water out of the bowl. Sorry, it's not me. Just in case you were wondering. Okay, we need to comply with the standard of care. This is beyond ethical, it's legal. Okay, when there is a standard of care or a policy and procedure, I'm looking down the list here, this is something that our Nurse Practice Act says we have to do. But if there is a, just a standardized way, a good way of doing things that may not be part of the standard of care, but is the culture of the nursing unit, that, or maybe it's the mission, philosophy and mission statement of the unit, doesn't necessarily fall in the policy and procedure manual, we want to follow through with that. We want to comply with that. We want to be all consistent in doing that. we are, as the RN, a supervisor. Once you become the RN and you get that legal title and that license, you are in charge of supervising others, and that's vitally important there. So this again was something that was read. If you were started in our program from fundamentals, you can go and remember that that is the case. And you can go onto the BRN website and see some links in terms of supervisory responsibilities of the RN. They have a paper on that on the website. Okay. We need to always adhere to the nursing process, and we work with that all the way through the curriculum with you. It's not just about writing a care plan and the routine of writing a care plan, but actually following through. And in Skills Lab, we talk about that, especially when we're looking at the disaster skills lab. We're going through and analyzing the care plan and making sure everything adds up, that the assessment supports the problem or the nursing diagnosis, that the plan is able to be measured and followed, and that the interventions get you to reaching that plan or those goals, et cetera, et cetera. So that we have to do. Follow up as required, and that is in terms of evaluating how our job has, how we've been doing our job with the patients. We need to definitely follow up on that and continuously assess and monitor. And we need to also develop and maintain a good interpersonal relationship with the patient and family if the family is involved, always in terms of that. And then lastly, document carefully and document legally. So bringing back to you, what are the necessary points of documentation? Again, review, but we sometimes forget about those, and we don't want to forget about those because this is a big deal here. So let's look at the next slide. And documentation do's and don'ts coming up. Let's look at the do's. Documentation needs to be timely. Documenting right then and there when things are happening is important. And you might have noticed that how constantly your nurses are documenting all the time. Waiting to document creates a lapse in information. So you want to make sure you're documenting right away. This is something that you'll see as you go on through the program and you're in Med-Surg. So this is really great when there is a computer in the patient room or right near where things are happening. So I know we see this at County because the computers are on wheels and they're scattered about and they're with the nurses. And so the nurses can document readily right then and there on the spot. Now, when some of you go to the Med-Surg unit at County Hospital, you'll see that those computers are also on wheels and they have to be moved into the patient room, where other facilities will actually have the computers right in there. So creating that necessity of doing some documentation timely. Okay, the dog is now eating, so you hear crunching, and again, that's not me because I can't talk and crunch like that at the same time. All right, moving along. Knowing the standards, knowing what the policy and procedures are, knowing those all the time, the standards of documentation. And this is very loose amongst nurses. They don't always document the same way. You'll have one nurse that says, well, document this way. And you'll go to the next nurse you'll work with another week, and the nurse will say, well, no, you don't document that way, you document this way. Well, that is always an issue when we're learning from others. By the way, there's always a standard, and it's in the policy and procedure manual of how to document. So the next bullet point is on the left side there. It looks at legible when writing. Well, you might think that, oh, electronic documentation is everywhere. It's just in acute care. You can pretty much just count on that. I was talking with one of our fellow instructors who also works as an ICU nurse, and she was telling me that some things are documented by hand in ICU, and then other things are documented electronically. So anytime you're documenting by hand, and by the way, she was talking about eyes and nose. And you might remember that from the pediatric IV competency that you had to do in Skills Lab. You have to write legibly. That is important. We see it all the time looking at the psychiatric emergency room. All the documents are written by hand down there, and only the physician's admission and summary or discharge summary are transcribed into the electronic format. Everything else is by hand, which means it's a challenge when trying to read legibly. So get used to it. There are things that are written by hand. Long-term care, subacute care, all by hand. Wow. Okay. Full, accurate, objective descriptions. This is important. If you want to convey what you were seeing or assessing on a patient to the next person that's reading it, well, then you have to be very descriptive. I like to say, paint a picture with your words, meaning that your words need to fully describe what's going on so the next person reading that could actually imagine and see it for themselves with your words. So important to do that. Chart your senses, what you see, so important, really do that. And again, paint a picture with your words. What you hear, subjective sayings from the patient. What you might touch or feel, palpate on your patient, percuss on your patient, so very important. But use discretion when you're here in the psych unit. Of course, you're not going to be doing a lot of that unless it necessitates that you have to palpate and assess with what you're to touch a patient. And then of course what you smell. And by the way, yes, that's a very important thing to do. We do have to record that. Sometimes it's very important in the description. Complete assessments in the time allocated. This doesn't mean necessarily in the time that you have a shift, like for 8 hours. You have that whole time to complete all parts of the documentation. This is true, but the important things need to be documented right away. Always vital signs within an hour of your start of shift have to be documented. Your priority assessments, the things that are really, really necessary, those key areas to assess. And when you see in med-surg, that becomes very, very important. Those need to be documented within the first couple of hours of your shift. Then you can get to the rest of those things. So in psych, there will be key areas that need to be assessed right away. Perhaps some of the important scales in terms of, contracts that you're working with on the patients, and no harm contract and what have you. Those are vitally, vitally important. Of course, meds have to be completed and charted within a distinct time frame. This next slide continues with the do's. All those pertinent observations, especially the behaviors, physical symptoms, the things that you can see, so very important. Document on any previously unresolved problems. That means you're documenting on the care plan. And then once a problem is resolved, you don't have to document on that, but make sure that you document that it's been resolved. And from that point, document anything you do, all your teaching, all your treatments, anything you do with the patient, any intervention needs to be documented. So important. And again, I already said this, the patient's subjective responses, not yours. Oh my goodness, how many times do I come across these subjective statements that nursing students make? And nurses really, really get very proficient, our RNs, registered nurses, of how to not use your own subjective or personal interpretation of what's going on with the patient. Subjective for the patient statements, vitally important. Your subjective opinions or assumptions, not to be done. Totally not to be done. Chart discharge instructions. That falls under the previous bullet of everything you do. If you're discharge teaching or giving instructions, so important to document this. You're documenting what you taught, but the really super important thing here is, did the patient understand? Now, we can't document patient understood and just leave it at that. How did they understand? they were able to state back the primary symptoms to look out for or side effects. You need to document that. The failure of electronic documentation is that there might be a box that says the patient was able to understand this, and it doesn't elaborate any further. And so it's a quick and easy thing to check, but you haven't really checked the patient's understanding. Today, as I'm speaking, the current state of discharging a patient, if you discharge a patient and you give them instruction and they go home and, well, return because they failed to understand what the instruction was, and they return with that same problem, then there's a great potential that the insurance company will not reimburse for that. So hospitals are very much emphasizing the teaching and the evaluation of that teaching. So you must evaluate a patient's understanding. They need to repeat back things to you. It becomes a little bit of a slippery slope when they go home and they decide not to do those things. And sometimes we can't prove that that is the case. But in any case, that's a very, very big thing. You will see this coming up in terms of especially our med-surg units where there are a lot of patients going directly home to care for themselves. Our patients here in the psych setting usually are going to another level of care in a lot of cases, and then that's the case we're making sure that next level of care knows what the patient needs to know. All right, and then the next column over, it says you document when you've notified the doctor or a clinician to come see the patient, at what time, and then you document what time they arrived. And if they didn't arrive in a prescribed amount of time, then you document that you called them again. And if they didn't arrive still, you document that you called the supervisor of that individual to let them know that you've been trying to get that individual to come. You document all the time. You document, okay, so I see that there, when the patient was visited by the practitioner. Okay, we got all that taken care of. And then when there's an unusual occurrence, incident, event, whatever they're calling it these days, you document the facts surrounding that. Not in your ongoing progress note or in your standard documentation procedure. This occurrence, unusual event will be documented in its own format outside of the usual patient charting. That's important. Next slide. So what you don't document. What you're not going to document, you do not document the incident. Like I said, it's been filed. It's privileged or hospital privileged communication. So any type of incident, unusual occurrence goes on its own documentation. It's for review by the hospital. You will chart you don't chart, sorry, a little tired here. You don't chart your own opinions. That's your subjectivity. You don't defame or use derogatory statements, and you can go ahead and find plenty of those. There's Google examples on that, I'm sure. And of course, if you're doing any type of written charting, you do not erase, obliterate, or leave anything blank if using paper or pen documentation. If you're using electronic documentation, of course, you cannot erase. Usually that has it built in that you're not able to do that, especially once you press submit on or save or whatever the electronic format is. So, but you can leave some things blank. Some electronic documentation systems will alert you and say you can't move forward. You got to go back and fill that document out. But some are not as high level, and if you leave it blank, we know what happened about that. Leaving something blank means it's not done. And speaking of done, I'm done, and you have a good evening or day or whatever time you're listening to this. Toodaloo.